Hi, everyone, and welcome to today's webinar, Caring with Compassion, Supporting Patients and Families in a Crisis. I'm Stephanie Adler-Yuan, Director of Education and Training here at the Schwartz Center for Compassionate Healthcare, and I'll be your moderator for today's session. We're so grateful that you were able to take the time out to join us today. This Compassion in Action webinar is a program of the Schwartz Center for Compassionate Healthcare. We're a Boston-based nonprofit organization established 25 years ago in 1995. Many of you, I believe, are familiar with our flagship program, the Schwartz Rounds, which is offered in hundreds of our member organizations around the world and provides caregivers from all healthcare professions with a forum for discussing the complex emotional experiences of caregiving. Okay, we're going to get started. Before we do, there are a few things we'd like to note about today's session. First of all, this special series of COVID-19 focused Compassion in Action webinars is supported by the Coveris Community Foundation, and we're enormously grateful for that support. Today's program is going to last about 60 minutes. We'll have a presentation for 45 minutes. That'll be followed by a 10 to 15 minute Q&A. We'll see what we have time for. And although all of our attendees are participating in listen-only mode, we encourage you to interact with our speakers using the questions pane on your GoToWebinar control panel. I also want to add that we know that so many of our colleagues will be unable to join us today, and so we will be recording and posting this program to our website tomorrow, along with a handout of the presentation slides, so you can keep an eye out for that. Last but not least, as you exit this webinar, you'll see a very brief survey, just a minute, that will ask you to complete so we can capture your assessment of today's program. We read every single comment. We really appreciate your feedback. And now, it is my absolute pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is Chief Medical Officer of the Schwartz Center for Compassionate Healthcare, and she's also an Associate Professor of Medicine at Harvard Medical School. Welcome, Beth.
Thank you, Stephanie. Good afternoon, and thank you all for joining us for today's Compassion in Action webinar. It's absolutely my pleasure to introduce our wonderful speakers, starting with Patricia Watson, PhD, who has been a clinical psychologist at the National Center for PTSD since 1998. Before then, she was an active duty Navy psychologist for 8 years, received her doctoral degree from Catholic University and postgrad fellowship in pediatric psychology at Harvard Medical School here in Boston. Dr. Watson has written widely about disaster mental health interventions, early interventions for traumatic stress, resilience, moral injury, and many other topics. She's the co-author of the Combat Operational Stress First Aid for Navy and Marine Corps, multiple versions of stress first aid for firefighters, emergency services personnel, law enforcement, and many other professions. Thank you so much for joining us again, Patricia.
Thank you so much, Beth. It's a pleasure to be here again.
And also joining us is Dr. Richard Westphal, her partner in this work, who also joins us from the University of Virginia, where he's professor and Woodard Clinical Scholar at the School of Nursing. He's also a retired U.S. Navy captain, a PhD prepared researcher, and a dual board certified advanced practitioner, mental health nurse and nurse practitioner. His clinical work has been, and his research has been focused on traumatic stress, occupational stress injuries, and mental health promotion. And he's currently the chair of Family, Community, and Mental Health Services Department in the School of Nursing and the BWISE co-director at UVA. And we're very pleased to have Dr. Westphal here with us as well today.
Thank you, Beth. It's my pleasure to be here with the team again. Thank you.
So we're all really eager to get started. So I'm going to turn this program right over to you two.
Okay, so I'd like to go ahead and start with a bit of a review and an introduction to some of the concepts around stress first aid. And when we think about stress first aid, it's important to recognize that it's designed primarily as a peer support model and that peer support has several assumptions. One, that it's with people who know each other and connect over time. People who have ongoing moderate to high level stress experiences. And this is a framework that can be used to identify those people that we know, that we work with, that we engage with over time, to identify issues of distress, acknowledge that distress, and then help them connect with resources. It's important to recognize that as a first aid model, this does not replace spiritual care or mental health care services. Now, today we're going to be focusing on how do we support patients and families. And so the stress first aid model can be a framework that we use for recognizing and engaging with family members and patients in these high stress environments. And we can do this because it's a framework that we can use for peer support. And the way that we can use it with patients and families is that the healthcare experience often creates peer type bonds between families, between patients, and the healthcare team members. When we think about crisis and critical care, it often intensifies these intra-healthcare bonds. And so what may take weeks and months in an occupational setting can seemingly happen in hours or days within a healthcare setting. And one of the ways that we recognize that we extend this envelope of unit cohesion to our family and patients is it's fairly common for healthcare professionals to say, you are part of our family now. We are in this together. So when we take a look at stress first aid, this is the third in a series. So I know that we have some people that are joining us that have not yet watched the first two webinars. So this will just be a really quick overview. Stress, we think of three models with stress first aid. We have stress as a continuum. We use a color-coded schema of green, ready for life events, using well-being perspectives, and we want to talk about growing the green, growing our resilience and our capacity for well-being. Yellow are normal and expected reactions to stress. Orange indicates behavior changes that will tell us that a stress injury might be occurring and that we can use peer support strategies to promote recovery from stress injuries. And red indicating sustained stress-related illness and reactions that need professional help for recovery. The next framework is that there are four sources of stress injury. Ways to think about this is four sources of stress that tend to really fundamentally derail or challenge life expectations. There's life threat and trauma, there's loss and grief, there's inner conflict and moral distress, and there's wear and tear associated with fatigue, sometimes called burnout. And finally, when we recognize that there is a stress injury, we have a model that we can use to support those who are at risk for stress injury by assessing and paying attention to 5 essential human needs. And these essential human needs cover a focus on safety, calming strategies, connection strategies for social support, competence and coping strategies and problem solving, and confidence and hope for the future. So when we think about applying the stress first aid framework for assessment and support actions, notice what we can do with this. This is called the 4x5 assessment and intervention framework. It can be used by healthcare professionals to acknowledge potential sources of stress that may be relevant to the patient and the family. And trying to understand the psychological needs of patients and families can seem a bit daunting as there's so many issues and so many variables that we're trying to pay attention to. And the 4x5 assessment is used throughout a patient's treatment and facilitates understanding that the issues of greatest concern in early treatment, such as safety and calming, are likely to be different from concerns later in treatment, such as coping and confidence in the future. And by using the 4x5 assessment, the healthcare team can begin to focus on where there's greatest challenges and opportunities for interventions. And instead of 1,000 different variables, we have 4 sources of stress injury, 5 essential human needs. There's really 20 critical decision points that we can use for doing this assessment. So when we think about the framework for assessment and support actions, that there are some questions that we can use. And the first set of questions are really about understanding the exposure and how would we recognize whether it's trauma, life threat, loss, inner conflict, wear and tear. And so the assessment starting with these questions would be what behaviors indicate that the patient may be having a stress injury? What sources of stress injury may be present in this situation? Just because somebody is in a crisis or admitted to a hospital doesn't mean that all of these sources of stress injury are in play at any given time. It's important to think about what information are we missing and how do we get that information and who else do we need to talk with to help us better understand the impact of the recent life events on the patient or the family. So once we have a sense of what sources of stress injury are potentially in play, then there's the questions of the assessment of the psychosocial impact. And this is where we really use the 5 essential human needs. And we focus on behaviors. What are the behaviors that indicate that there's an issue around safety? Is there fear? Is there hypervigilance? Is there suspiciousness? What are the behaviors associated with autonomic arousal, anxiety, or panic, and could really benefit from calming interactions? What are the impact or the behaviors about social connections and their ability to have resources around support? What are some of the behaviors related to coping skills, problem solving, making decisions, give us clues to competence, and confidence about hope in the future? What are behaviors related to the connections with deeply held beliefs, the presence of hope, or meaning? As we unfold some of these aspects around assessing and actions for patients and families, we have a case study, and we're not going to go into deep detail in the case study, but we'll use it as a couple of reference points. So just to walk you and introduce you to the case study, I'd like to introduce Emery and Riley. This is a relatively young couple, and after graduation from college, they've been married for 5 years. They have a 2-year-old daughter. Riley is in her second trimester with their second child. They live in a large urban center without nearby family, with high cost of living, where both of their incomes are absolutely essential for covering basic expenses. Early in the COVID-19 pandemic, Emery was not concerned about physical distancing, did many behaviors that were contrary to what the recommendations were. And other than feeling tired with some deep muscle aches, Emery was feeling okay. Then one evening at dinner, Emery experienced signs of a stroke and became unconscious. Riley called 911, which Emery was then transported into a hospital. And so in this case, we will preset that there's sources of stress injury, trauma, life threat. When we think about the impact of a stroke and major stroke, we see that fear and helplessness that can come into this. There's obviously a loss of normal routine. There'll be decreased income, increased expenses associated with healthcare. There's fatigue related to pre-injury stress in working double shifts and the challenges of just managing life before the COVID experience hit. Uncertain recovery, then there's work and childcare issues, and then inner conflicts start to come up around questions regarding the illness circumstances. So that'll be a context that we'll take a look at a couple of the actions. So with that, I'd like to go ahead and turn this over to my colleague, Patricia.
Thank you so much, Richard. So, and I appreciate the introduction to the model again. I would like to just say a few more words about how we thought through applying this model to patients. When we originally developed the model, it was meant to be for military, then first responders. When we took it to first responders, part of what happened was they said, look, we may not be using this every day for a peer support model, so we would like to have it also be applied to our work with the people that we're serving, the public. And that will give us two things. Number one, it will allow us to remember the model and remember the framework when we do want to use it for peer support. And it will also improve the work that we do with the public, because we are really well aware that the people that we work with are often stressed. So as Richard said, it was designed originally as a peer support model. However, when you're thinking about it in terms of patients and family members, there are a few different ways to use it. One is the assessment grid that Richard talked about. However, I'm also aware that many of the people that are using it more as an organizing frame in the moment as they work with people, and aren't thinking in terms of using it in a more systematic way with a grid. The idea is that, particularly at a time like this, as Richard said, you are the family of the person in front of you, especially when they're not able to have their family there. You are the person who is there with them at a time when they might be the most fearful they've ever been in their life. And we used to say in our trainings that this model is really meant to say, how would you treat a family member? Treat the person in front of you as you would a family member. And we used to get comments in our trainings. People would laugh and say, "You don't know my family. I'm not sure you want to say that." So we ended up changing it to treat the person as you would a beloved family member or friend. So the idea is just a good bedside manner, really. We called it curbside manner with first responders, but it really comes back to that idea of good bedside manner with a person. And in a time of a public health crisis like this, I think it's particularly important because they won't have the same connections with people as they do on a regular kind of day that they would still be having one of the worst days of their life. So the idea is that you use the framework in a flexible way, depending on what's in front of you, depending on who's in front of you. And the same principles apply, as Richard said. You're really trying to make a connection with a person in a helpful and respectful way to restore their safety, to calm or orient them, to connect them with their sources of support in whatever way makes sense at that moment, to improve their ability to address the needs that are most critical to them, and to foster a sense of hope or limit their self-doubt and guilt. Now, I'm really well aware that this is a hard conversation to have on a webinar because many of the people on this call are just preparing for something that's yet to come. They are using maybe this framework already just in the course of thinking through how to be a good provider. But with a public health crisis like this, I'm aware there may be some people on the phone that are dealing with very intense situations. So that's what I like about the framework being flexible. You use it as it makes sense in the moment with the person who's in front of you. When you are depleted yourself or you're too busy yourself, you do the best you can to have a moment of connection with a person. When you have more time, you spread it out and you try to do more of the core actions of stress first aid. So as an example, Richard and I are going to go back and forth with, and I'm realizing that my controls, let's see, I need to go to the next slide. We're going to go back and forth with the slides and the case study. So each one of the core actions, we tried to come up with some simple strategies that we had heard first responders and people in healthcare and environments are using with people. Again, as I've said on other webinars, I hope that this webinar also reminds you that what you're doing is important. When you take those moments or you try to think through, how can I help a person feel more safe? How can I demonstrate respect to them? And how can I help them feel like they're cared for? That when you do that, it really does matter, because people in situations that are uncertain, when they're scared, when they're fearful, they're much more open to that kind of care and kindness from somebody else. And it can make all the difference in the world to their recovery. We know that stress affects the immune system. We know stress affects the way a person feels like they can get through a situation. So if they've got somebody next to them that even shows the smallest amount of kindness and care, it can really make a difference in all of these 5 elements that we're talking about. So with cover, we have very, very simple things. We do not want this model to be something that is perceived as an extra burden. Like, oh my gosh, now I have to take care of the mental health too. No, it's meant to be used in the course of your duties. It's not something that we want to have add to your stress. If you can fit in these simple ways of connecting with somebody, then we think it will make a difference in their care. And we think that it is making a difference in their care, because I would imagine most of you are doing many of these things already. So please know that as we developed this model, we tried to make it simple for that reason. We tried to map it onto these 3 different ways of enacting each one of the core actions, that the way you approach a person, the way that you give and receive information, and the way that you direct them can make a difference in their care and their recovery. So with cover, it's things, as I said, like introducing yourself, asking and using their name whenever possible, conveying that you're there to help their situation and keep them safe. Some of us in these fields take some of these things for granted, but we may not realize that some of the things that you're doing now to help keep people safe are foreign to them, and they don't realize that you're doing it to keep them safe. And as Richard said, if you're seeing signs of paranoia or extensive fear in them, just a simple statement of the reason why I'm doing this is X, Y, and Z could really make a difference in their reaction to you. If you can ask about their concerns or give simple, accurate information about what you're doing next and why you're doing it, it can also help calm a person down and help them feel more safe. They might not understand your instructions. When people are stressed, they don't hear things the first time around, and slowing it down or providing it in a different way could make a difference. And just continually reassuring them of the steps you're taking to make them safe, why you're doing what you're doing, as we say, can really affect them. I've had people say that sometimes they'll engage a person in a simple conversation and ask them questions that don't really matter. You don't need to know everything, but you're asking the question just to refocus their attention and help them stay with you and not be inside their head with their fear. You're just trying to get them engaged so they're focusing on you and focusing on being in the present moment. And many of the suggestions that you'll hear us talk about today have to do with helping a person stay in the moment, so they're not overwhelmed by future fears or what just happened to them. And that includes giving them directions, telling them what to do rather than what not to do. If they need to be moved, you move them. If they need to be protected from information or people or situations, you find ways to do that. And it could be that you're also helping them with simple problem solving. If they have concerns, how am I going to convey, what's happening to me to family members or friends? You may be the person who helps them think that through and help them enact that. So I will stop there and move back to the case study as to how cover could be enacted.
Thank you, Patricia. So just as a orientation framework here, that because this is a trauma case, we're using the trauma phases as just a framework for talking about this case. So there's a resuscitation phase, a critical care phase, intermediate care phase as patients are moved out of the critical care units, and then a rehabilitation phase. And so when we think about cover in the resuscitation phase for Emory, it would be statements of reassurance. You are safe. Trying to communicate with the patient, even though we may not know if they can hear us or not. And our emergency responders, folks that work in ER, are absolutely great. And most of us that are healthcare professionals, we use these strategies all the time in the care that we do. And so part of this is just a reminder that from a lens and a perspective of being mindful and intentional about how we support people that have a stress injury while doing the work that we're doing is important. The thing that I'd like to pull out here and call your attention to is that the strategies that we may use in, say, the resuscitation phase would be different for the patient and the family member depending upon the context of their care, where they're at, and what their challenges are. So this is not a cookie cutter. This is, you do this at this point in time. It's a range of concepts. So in the resuscitation phase, we talked about reassure you're safe. And for Riley, it's going to be informed that Emory is in the ER. And in the time of COVID, it's really encouraging Riley to stay home. In the past, we would say, please come to the emergency room, be safe, bring somebody with you, come as soon as you can, as safely as you can. Now, the sense of safety is staying home. And as we move into the critical care phase, we see that particularly if there's an impaired ability to communicate, such as with a stroke or head trauma, if possible, can we develop a nonverbal communication with the patient? Is a signal or a sign that they can give that says pause in treatment, there's pain, or they need something? For Riley, it's going to be identifying patterns of communication. Does Riley have access to a phone, a web link, a video a chat? Is your particular facility set up with video chatting, or is it only going to be a landline? How are they going to communicate, and how are you going to communicate with Riley? I'm going to move us down to then the rehabilitation phase when we think about cover and safety, that Emory's going to be developing new skills. And how do we help Riley navigate those new skills with uncertain motor controls and what those changes are? And for Riley, as we see with many family caregivers, there's a risk of taking on more demands and not asking for help. And there's a risk of a compounding injury. So I'll turn this back over to Patricia.
Thank you, Richard, very much. It's strange to go back and forth like this, so I'm going to do my best because I feel like I get involved in the case study and I want to hear the next thing and not go to my slides. But I would say that my job is to also remind you all that there are lots of different ways to do this, and that's why we have the back and forth. So as I think that healthcare professionals are primarily going to be having a lot of overlap amongst these different core actions. So it's a little strange to offer it in a step-by-step way. I think it's more of a dance where some of the things you're doing that are going to help a person feel safe are also going to help them feel calmer and help them feel like they're going to be able to handle what's going on and get through it. But for a training, we have to be a little bit more linear here. So as I said, calm actions, we have a few more slides because we think that this is something that's particularly important. And these are things that, you would be doing regularly with a person across the course of your time with them. So keeping calm yourself, respecting their needs, just your presence, just being there with a person can help them feel more calm. Showing even a little bit of understanding. If they say, I'm scared, or I don't know what's going on, or they're showing signs of fear, you would validate that and show that you understand and say, I can understand how you would feel that way. In situations like this, it's really expectable that you would feel fearful. Just know that we're doing everything we can to help you right now. And again, give them guidance, give them information. Expect that you are going to have strong emotional responses, particularly in a time like this, and reassure them that you're doing the best you can, using your voice, using your gestures and your facial expression. On the next, my information slide is, again, asking questions, identifying and addressing what their most immediate needs are, and helping them if they're overwhelmed. You're collecting information and also helping identify resources for them. They may not be able to take much in. So some of this, is a laundry list that you will use for some people and not for others. We wanted you to have, different examples of how to use each one of these. But again, some of these things could be 1 second, to 10-second interactions that you have with a person. Because again, we want you to tailor what you're doing to the person's age, their culture, their gender, what's happening in the moment, and making sure that you're giving them information and taking information from them with a goal in mind of this is also going to be calming for them. Next is direction. So I think probably for me, the one that I see used the most here is emphasizing the present, the practical, and the possible. What are we doing in the moment? what's practical for that person and for the care of that person, and what's possible. And letting them know, look, here's what we're doing at this moment. We can only focus on the present moment. Help them identify some ways that they can calm themselves down. And sometimes distraction is the way to do that, with a TV show or whatever it is that could help them not think about some of the things that are going on inside of them at that moment, especially if they're feeling overwhelmed. Again, explaining things, addressing needs, and helping them to breathe, and helping them to do the things that in that moment they can control. On the next slide, we have some examples of statements, and I'm sure you'll recognize many of these things that you say to people. We have a great team here. We're doing everything we can. Do you have any questions? I understand, that you're going through a really tough time. You're feeling shaky. We're going to talk about this, and I'm going to be asking you this so that we can do this. We have a person here who can get you information about resources. Try to calm down. We're here to help you through this. Try slowing your breathing. This sometimes helps, and you can even breathe with them. I'm so sorry you have to go through this. Is there anything that we can get for you? So again, anything that expresses that kind of, we're here with you. We're doing our best. I am really well aware that there are going to be moments when you're stressed yourself, and these types of things are not possible. But what we're trying to convey is that they are important. They might feel like small phrases, small moments, but if it is possible, we really believe and see that it does make a difference for people. So I'm turning it back over to you, Richard. Richard, you may be muted. I don't hear you at the moment.
Thank you, Patricia. Sorry, team. When we think about calming strategies, these are some of the most prevalent and commonly used across the spectrum of care. And most healthcare professionals may not even think about calming strategies as a first aid intervention because it's just part of what we do. From distraction before giving an injection to guided breath work, we see calming strategies throughout the delivery of quality care. And one of the things that many of us will see is that when we're using a calming strategy, that may actually be the first indication that we have that this family member, this patient really has a stress injury on top of everything else that's going on. And so we've given a couple examples here from in the resuscitation phase, really trying to have just one or two key team members as the main communicators for Emory. When we get into the critical care phase, thinking about Riley, we want to encourage questions and give permission to ask the same questions over and over again, as family members need to do. And we can role model a calming breath as a way to focus and really try to help Riley maintain calm. And then when we get to the rehabilitation phase, helping Emory develop skills for focusing and tolerating repetitive treatments and frustrations, and helping Riley to engage as a care partner within the rehabilitation strategies. Thank you, Patricia.
Okay, so on the next slide, I'm going to go through this quickly. All I want to say is that we know that social support is important when people are in stressful times. In this particular public health crisis, this slide is highlighted for me as one of the most challenging aspects of healthcare right now, because people aren't able to be with their family members and friends in the same way. So I've seen examples of beautiful ways that healthcare providers have tried to be creative to get people connected using technology and using, simpler strategies with FaceTime, passing messages back and forth from patient to family and back to patient, finding different ways to convey information between family members and friends and patients. To me, this is where your creativity particularly now, is coming in and needs to be brought forward, because finding ways to get people connected is particularly challenging right now. So lots of different ways to do this, and sometimes it's not always possible, and you will be the social support for that person, or maybe you can find other people in the environment who are able to be that support for that person at a time when they need it. So it's really, again, a range of possible actions, from ones that could easily connect a person to family via technology, to a situation where it's not possible. And then we go back to basic core existential ways of saying, at least I can be here with this person, or at least I can have somebody be here with this person at a time when they need that kind of comfort and support. So I'll turn it back over to you, Richard.
Okay. So when we think about Connect examples, that during the time of COVID care, this particular element becomes critically important. It's unfortunate in many ways that the phrase that is being used is called social distancing, when in fact it needs to be physical distancing with social connectedness. And often the healthcare team becomes surrogates and conduits of connection for the patients, for the families. And the role that we play around supporting connections and social support is really critically important at this point in time, more than almost any other time or any other type of care. And so when we think about some Connect examples in the resuscitation phase, those are fairly obvious in maintaining a sense of physical contact and reassurance. When we get to the intermediate care, so Emory's made it through critical care, and we're now looking at intermediate care. We want to look for opportunities where patients support each other, celebrating successes. I think about some of the strategies that we've seen used in health centers across the United States, particularly health centers that have had a high number of COVID patients, playing a song, ringing a bell, celebrating extubations, and celebrating discharges as a community event within that unit or within that healthcare facility. When we think about some of the Connect examples for Riley, we want to assess link with other social supports related to child care and work, and most certainly venting frustrations and concerns. As we know, with patients that have critical illnesses and a really challenging recovery, that family members often are reticent to vent their frustrations, their anger, particularly with the patient or their loved one. And this is where we, as an extended members of their social network, of this augmented social support that we provide as healthcare professionals, and that we can provide that safe space for her. And then the last thing I want to point out here under connection is that both Emory and Riley are going to need to redefine their relationship, who they are as a couple, who they are as parents, who they are as people, given the experience that they have had. And many of us are going to need to redefine who we are now that we have had this COVID experience.
Thank you, Richard. So with this, the core action of competence, remember, has to do with self-efficacy, which is helping the person feel like they can get through a situation. So really the focus on this action is giving them either resources or skills. So you're going to be doing what you can to get them connected to resources, making it part of your job to facilitate growth, helping with them with skills that they may need in the moment, but also moving into the future. So you may get them connected with post-hospital care, for instance, where they could talk with somebody about, how do I move forward in my healing journey? What do I need to know? How do my family deal with their things, the things that they're worried about, or the things that they need to know, and the skills they might need to be safe? Maybe they need simple strategies and skills to know that they can be safe, that they can continue to to recover, that they can make sure that from this point on, there won't be similar problems to this because they've taken key steps to prevent them. So just finding ways, again, skills, resources, and ways to make a person feel like they can get through this, or a family to feel like they can get through this. I'll turn it back over to you, Richard.
So, whoops, let's back one. How do we go backwards? Thank you. So when we take a look at competence, a couple things I want to draw attention to here. Under the resuscitation phase, notice after Emery, we left that blank. So in this case, Emery has had a significant stroke with loss of consciousness. And so this is a way to remind us within this framework is that we don't need to do all of these every time. There may be situations or circumstances where it's not a good fit. And so this idea of helping to build coping competence for Emery while Emery's unconscious isn't a good fit. Yet we most certainly in this phase start teaching family members strategies for communicating with the team and how do they navigate with the ER team during this process. As we move through the different phases of care, we see that these are really different for Emery and for Riley. So in the critical care phase, as Emery starts to recover, to the extent possible, we want to engage in self-care activities. Now for Riley, it's a coping mastery for navigating physical distancing and not being able to visit Emery, and the challenges of wanting and desiring to be connected and helping, and yet often feeling isolated and separated from that process. When we think about the intermediate care for Riley, we want to encourage remote participation. And as we've identified in this COVID timeframe, how do we take the challenge of this physical separation and the additional communication barriers? And for many, this is developing new skills. Many of us have developed new skills around using webinars and Zoom and other products. And most certainly, we see that happening with our family members. So we all are developing some new skills during this time. And then when we think about competence within the rehabilitation phase, it's really reminding and engaging with what they have gained. Often during times of rehabilitation, people are focusing on what they have lost. And so it's often useful, yes, you've lost much within function and capability, but there's yet to be gains and you've come so far. And for some of our patients, the act of being alive and having ability to function and to regain skills is a significant milestone around competence. I'll turn it over to Patricia.
Okay, thank you, Richard. So for me, this core action of competence, remember it's mapped onto the essential element of hope. And for me, I think this is one of the most important elements right now, because hope is not, as we conceived it, is not just this kind of optimistic Pollyanna kind of view of everything's going to be okay. It's more about how do people in the moment deal with trying to move through a situation that has a tendency to pull forward despair, and how do they deal with that, and how do they in the moment try to take steps towards fighting a sense of despair. And so you may see this coming up in a number of different ways with people. Right now, the whole world is focused on the importance of healthcare providers and healthcare workers and how much they are on the front lines. So just by virtue of being with you, many people will feel a sense of inspiration by you doing the work that you're doing, and know that if you can do it, that they can do it. That in and of itself might be the way that you impart hope to people, just by your quiet dedication and you're continuing to move forward in a time that is very scary for most people. And many people have acknowledged that the frontline workers are the ones who are are the ones who are having to deal with that fear more than any of the rest of us. So by virtue of who you are, you're imparting confidence and hope to people. We also know that many people will come into situations in healthcare at a time like this with a feeling of having wished that they could have done something differently. I wished that I had taken more steps not to bring this upon myself or upon my family. And by you being there with a neutral or a more positive attitude, avoiding any kind of judgment, avoiding any kind of, comments that might validate that for them is very important. By also validating the fact that they're still here, they're moving through it, and that their family also is moving through it, can give them a different way of looking at things. Your job might be to simply kind of clarify their misunderstandings or the ways that they're viewing the situation by saying simple things like, it's really hard for any of us to be completely safe at any time. You did the best you could. And maybe also reminding people that no one is at their best right now. No one is at their best right now. Everybody's doing the best they can in a very, very, very difficult situation. And you're helping to redirect their thinking. Many people also might be angry, and you might, just by virtue of being calm and in the moment, focus them on the fact that, yes, it's natural and understandable to be scared or fearful or angry. However, how's that working for you right now? Let's look at what might work for you right now. We know that when people stay focused on what they can do rather than the things they wish were happening, they tend to be able to take a step at a time, and that they are not going to be as likely to feel overwhelmed or angry all the time, which isn't always good for them. So you're just putting a person back to being on task and practically focusing on what they can do. And then also providing a positive reinforcement for any steps they take towards recovery. Same with the family. Anything that they're doing, you're there to just point out, you know what? Good job. Good job. This is great what you're doing right now. And look at the progress you've made from here to there. So I'll turn it back over to you, Richard.
Okay. Thank you. And let's see. So I'm not going to go through the details on this, and that Patricia did a good job of covering the elements that we see around confidence actions. And so within our case study, here's some suggestions for your consideration. What I'd like to call attention to is that issues around confidence is where we often see challenges related to moral, ethical dilemmas, moral injury, moral distress. And some of the words that you will listen for and hear, not only amongst patients and family members, but also our coworkers, is could have, should have, ought have, if only. Those are the echoes of shame and guilt, of moral injury. And so around this idea of confidence and hope for the future, moral injury as a source of stress injury in particular can become really a blocking process that needs to be worked through. So listen for these concepts of excessive or out of context of levels of guilt and shame. So I'll turn it back over to Patricia.
Okay, thank you. I just will give a few key points and we can open it up for questions. So remember that we're not saying that you're required to use the stress first aid framework with every patient or family member. I would imagine that most of you are already incorporating some of what we've talked about today with every person that you work with. Mostly what we see is that people in healthcare settings incorporate these actions into their duties in a very natural, seamless way, and in a way that doesn't interfere with primary duties. But we have seen that when people do incorporate them, that it actually makes some of their duties flow more easily because the person is with them, knows that they're supported, and so therefore is more adherent and more able to talk and be open to conversations. Remember, I think if you could remember nothing, one of our co-authors has said that the connection you make with people will help them recover from the overwhelming stress of what they've been through. They won't always remember what you say to them, but they will remember how they were treated. and how you made them feel. And family members as well will remember that. So by respectfully conveying that those people in front of you matter, we really believe, from looking at all the research on stress and functioning both health-wise and emotionally, that you will help them get through the difficulties they face and help them recover both physically and emotionally from the situation that they're in. Again, I think people really are looking to healthcare workers right now at every place in the healthcare organizations, from transportation to food service people, everyone who's in the healthcare setting right now. People are really seeing how important it is that the work that you do and the way you're doing the work that you do. And so even those who you aren't touching in your day-to-day work, people who aren't coming into the hospital, are being affected by the work that you're doing. Everyone is looking and saying, how grateful they are and how appreciative they are. So many of you, I hope you know that no matter what you're doing, no matter how you incorporate these actions in your day-to-day work, you're already serving to inspire people and help them feel more hope just by virtue of coming to work every day and continuing to do the work that you do. So we thank you very much for that. And we wish you the best in the work that you're doing. Then I'll turn it back over to you now, Beth and Stephanie.
Thank you so much, so very, very much, both of you. It's really a great model, and I have to say we're getting so many comments in the chat and questions box, just attesting to how powerful and effective this model really is. We do have a lot of questions, so I'm gonna pass some of them on to you. And I think these really reflect how people are feeling in the moment, but many people are wondering how to manage their own feelings of not being able to do enough because they need to limit the time in the room. And I think caregivers are feeling this way. And perhaps patients are, feeling a little bit lonely in these rooms as well. And I just wonder if you could comment on how you develop connection when you kind of have to limit your time together. I wonder if I could just turn that over to perhaps to you first, Patricia.
Yes, and I would say that what I'm seeing is that again, this is one of the reasons I get very frustrated with a webinar type of thing, because it's hard to see you and know exactly how things would apply in specific settings. What I would say is that we sometimes have to look at the situation and say, I'm doing the best I can. It's not an easy situation to make a connection. So I have turned to looking at posts that people have, articles, how people are doing this, and they're finding, different ways to do it. So everyone's going to do it differently. It's hard to give you a list of ways that people have done it. But I think what the theme that I'm seeing is that we have to realize that even a little bit is going to have to be enough right now. So even a little bit of taking a moment to breathe yourself, to talk to somebody and saying, this is too much for me, and having the person not fix it, but say, I get it. A fellow coworker to say, yeah, I think it's too much for all of us right now. We're really being tested. And just to be able to have a moment where you can share that with a coworker and then go into interacting with patients and families and be authentic in the sense that, as I said, you can acknowledge this is not an easy time for anyone right now. So it's understandable that you would feel scared, especially around not being able to connect with family at a time like this. And then ask, is there any small thing that we can do to help? And do your best to try to be creative, as I said. Even those of you that are most overworked, like I said, and your operational tempo is so high, just realize there may not be much you can do, but any little thing that you can do is moving in the right direction, right? I've seen people do small things, just to convey something to a patient, and it's all you can do. But the point is that you keep trying to find those creative ways to make the connections.
Thank you, Patricia. I think we have maybe time for perhaps one more question, even though we have some wonderful questions here. But Richard, I just want to ask you a little bit about the best ways really to help busy clinicians learn these skills so that they can really use them. Do you have any thoughts about that?
Absolutely, great question. So the good news is that most clinicians use variations of these skills throughout their day-to-day work. And so part of the advantage of the stress first aid framework is that it helps us understand that there's a framework that we can use for developing these skills. It also helps us to train new members, and for those of us that are very experienced, to explain to novice colleagues why are we making the decision that we're making. The other thing that's really important here is going back to this idea of 5 essential human needs. And we really do need to pay attention to messages around safety and actions around safety. That the strategies that we use around calming each other, calming ourselves, calming our patients and families are really first aid measures that help individuals to be able to connect with care, to be participants in their care, and to make it through the treatment, through the shift, through the day. And so these 5 essential human needs become a framework for helping us be economical with our effort and our time and thoughts. And as we develop the skills, to remind each other, you see a coworker do a good job with calming a patient or a family member or another coworker, to call attention to that. That's part of growing the green and building confidence. You know, Mary, we've been working together. That was a great, action that you did with that family member. Thank you so much. So those would be some ways to reinforce this.
Thank you so much, Richard. I'm afraid we're going to have to start to wrap up. I do want to let everyone know that we will be posting these slides on our website tomorrow, probably by noon, I believe, Eastern time. So you'll be able to listen in again if you wish, and to see a PDF of the slides that are available for download. Also, I want to let people know who are listening, if you are a member, if your organization is a member of the Schwartz Center, we are going to be releasing a training package that we have developed in collaboration with Patricia Watson, and we will be making that available so you can learn how to do stress first aid, and you'll have a training package you can teach others. You can integrate this with your peer support networks and also share it as a method for caring for yourself as well. So with that, I'll turn the webinar back over to Steph to close us out.
Thanks so much, Beth, and thank you so much to Dr. Westphal and Dr. Watson for a third wonderful webinar for our community here today. So we hope you enjoyed the session. We have a great slate of speakers continuing to join us over the next few weeks, so we hope you'll be back. In a week, we have Dr. Tony Back of University of Washington and Vital Talk, and we'll really be focusing on communication in the age of COVID, which I think is so relevant to all of us now today. We've got a few more treats in store as well, but we'll be hosting these webinars through May. So keep an eye on our website. And last but not least, we're really excited to share news of our 2020 Compassion in Action Conference, which will be virtual this year and will be starting in mid-June. So we'll have an outstanding series of workshops, panels, speakers. We hope it'll really feel a lot like our in-person conference, which will be resuming in 2021. So take a look at compassioninaCtionconference.org, and we hope you'll join us there. Until then, we know you're busy. We would love your feedback on our very brief survey. If you can take a minute to complete that before you leave us today. And if you'd like to learn more about the Schwartz Center, about membership, follow us on social media, take a look at our website. We're glad you were able to join us here today. Take good care. We are so grateful for everything you do. Bye-bye.